He tells patients that noticing the pattern is not betrayal. It is not ingratitude. It is not evidence that they failed treatment. It is evidence that bodies change, brains change, and medications sometimes need to change with them. The hardest conversations in medicine are often not about whether a drug once helped. They are about whether it is still helping in the same way now, especially when the person taking it can feel something slipping, but cannot yet prove what it is. And if a medicine protecting the heart can still blur the mind in the wrong person, the next drug is more alarming, because it calms panic by slowing everything down. Number 4 is amitriptyline. Some people know it as an antidepressant from an earlier era. Many others are given it for nerve pain, migraines, or sleep. That versatility is exactly why it slips past suspicion. When a drug is prescribed for so many different reasons, patients stop thinking of it as a heavy hitter. They start thinking of it as a practical solution. Something for the headaches, something for the burning feet, something to finally let them sleep. Dr. Williams says that assumption is where the danger begins, because amitriptyline can look small at bedtime while acting large inside the aging brain. Amitriptyline is one of the most anticholinergic medications still used regularly, which means it strongly blocks the same acetylcholine system tied to alertness, memory, and learning. In an older adult, that burden can be enormous even at what seems like a modest dose. The person taking it may not look dramatically sedated. They may simply become slower, less crisp, more forgetful, and more easily overwhelmed by tasks they once handled automatically. That subtle shift is exactly why families miss the connection until the person affected already feels as if some essential part of them has begun drifting out of reach. What makes number 4 so destructive is the timeline. People are often started on it at night because it helps with pain or sleep, and because the first few weeks feel manageable, they assume the long-term cost must be small. But months pass, then years. During that time, the brain is not just reacting to one sleepy evening. It is living under repeated chemical pressure. A person starts to lose words, then confidence, then spontaneity. They begin avoiding long conversations because they cannot trust their recall. They stop volunteering to drive at night. They let other people answer questions for them because searching for thoughts has become exhausting. Dr. William recalls a former choir director who came to him convinced she was slipping away. She had started amitriptyline for nerve pain after a back injury. At first it seemed like a blessing. She slept better. The pain softened. But over time she lost the speed that had once defined her. She forgot familiar lyrics. She missed cues. She stopped leading rehearsals because she could no longer trust herself to stay one step ahead of the group. The pain medication had solved one problem. It had quietly stolen the part of her identity built around timing, memory, and mental precision. That is what makes these medication stories emotionally brutal. The changes often attack the very abilities people use to recognize themselves. Memory, timing, language, initiative, social confidence. The losses feel personal because they are personal. The person is still there, but dulled, slowed, and pulled slightly out of reach. Families grieve before anyone knows what they are grieving. They think they are watching a disease unfold, when in some cases they may be watching chemistry do its slow work in the shadows. Then the countdown reaches number 3, the one Dr. Williams says almost nobody expects because it comes wrapped in the reputation of a newer, gentler antidepressant: paroxetine. It sits in the SSRI family, which many people assume means modern, mild, and safer than the older drugs. But paroxetine carries a complication that sets it apart. It has meaningful anticholinergic activity. That detail changes the story completely for older adults, because now a medication taken to steady mood or soften anxiety can quietly begin interfering with the same memory-vulnerable system damaged by other drugs already on this list. A person may be prescribed paroxetine for anxiety, depression, or both. The goal is relief. Relief from panic, relief from sadness, relief from the mental storm that makes everyday life feel impossible. Yet over time, some older adults find themselves dealing with a different problem. The emotional storm quiets, but so does something else: mental sharpness, word retrieval, short-term recall, the pace of thought. The change does not always feel dramatic enough to name. It can feel like the mind has become padded, slower to react, slower to reach, slower to trust itself. That is why paroxetine can be so deceptive. It looks like a modern answer. It sounds gentler than older antidepressants. It belongs to a class many patients consider familiar and safe. But in aging brains, the hidden anticholinergic effect can matter more than most people are ever told. Dr. William has met older adults who could not understand why their mood was calmer while their memory felt less reliable by the month. One man described it in a sentence he never forgot. "My panic got smaller," he said, "but so did everything else." This is where families often get lost. They assume depression is causing the forgetfulness. They assume anxiety is making concentration impossible. Sometimes that is true. Sometimes the treatment itself has become part of the cognitive story. And that brings us to the final reveal before the top two. Number two is not usually started because a person wants clearer thinking. It is often started because somebody wants behavior controlled, sleep forced, or agitation reduced. That is precisely why what comes next may be the most disturbing turn in this entire countdown. That is why number four frightens Dr. William more than many people expect. It does not always shock a family in one dramatic moment. Instead, it erodes certainty. The person taking it becomes hesitant in places where they once moved quickly. They begin apologizing for pauses that never used to exist. They withdraw from noisy rooms, complex plans, and spontaneous conversation. By the time anyone identifies the medication as a suspect, the person may already believe the decline is their fault, their age, or their future. That is what makes the next step so unsettling. Number three steals clarity while pretending to preserve balance. Number two goes further. It can make families believe someone is calmer and safer while the mind itself is being pressed into silence right now, tonight. Number two is the antipsychotic category. Names like quetiapine, risperidone, and olanzapine. These medications were developed for serious psychiatric illnesses, yet in older adults they are often used for problems that look very different on the surface. Agitation, restlessness, sleep disruption, hallucinations, behavioral symptoms. In care settings, they can also become chemical shortcuts when a confused, frightened, or overwhelmed person is hard to manage. Dr. Williams says that is where families need to ask sharper questions than they are usually encouraged to ask, because the first effect can look helpful while the deeper cost stays hidden. The person becomes quieter, less reactive, less combative, less restless at night. Staff members may report that things are easier. Relatives may be told the medicine will take the edge off. But what does that phrase really mean? In many cases, it means the brain has been pushed into a slower, flatter, less responsive state. Not healed, suppressed. The problem is that suppression can be mistaken for stability, especially when everyone around the person is exhausted and relieved that the visible chaos has finally settled. A calmer room does not always mean a healthier brain. These drugs affect dopamine and other signaling systems that help shape motivation, attention, planning, emotional expression, and mental speed. Reduce those systems too aggressively in an older adult, and the result can be devastating. The person may look calmer, but they may also look absent. Their face becomes less expressive. Their responses come slower. Their interest in conversation drops. Their balance worsens. Their fall risk rises. In some cases, families feel as though the person they love is disappearing in front of them, while still sitting in the same chair, breathing, eating, and technically remaining present. That emotional contradiction is one of the hardest things Dr. William has ever had to explain. A daughter may say, "He is easier to care for now," and then burst into tears because the quiet comes with emptiness. A spouse may feel guilty for being relieved that nights are calmer, while also grieving the sudden flatness in the person across the table. The medication reduces chaos, but it can also reduce personhood in ways nobody explained clearly beforehand. Families are left wondering whether they are witnessing relief, decline, or something much darker hiding in between those two experiences. Dr. William remembers one family who thought they had reached the final stage of decline because their mother had become so blank so fast. She stared for long stretches, spoke less, needed more prompting, ate more slowly. They assumed the disease had suddenly accelerated. What had actually changed most dramatically was her medication list. An antipsychotic had been added after a stretch of nighttime agitation. The agitation improved. Everything else dimmed with it. The family had mistaken chemical suppression for irreversible progression, and that misunderstanding almost changed every decision they made from that point forward. That is why the key question is not only whether the drug helped, it is why it was started, whether the target symptom was truly dangerous, whether other causes like pain, infection, poor lighting, constipation, medication interactions, sleep disruption, or simple overstimulation were explored first, and whether the dose is still necessary now. Too often, once these medications enter the picture, they stay. The crisis passes, but the chemical restraint remains. Then the person lives under that burden so long that everyone forgets what they looked like before the prescription was introduced. And that leads to number one, which is not a single medication at all. It is the hidden force tying this entire list together. The reason one nighttime sleep aid matters more when a bladder pill is added. The reason a pain medication becomes more dangerous when mixed with a PM cold formula. The reason an antidepressant, an allergy tablet, and a prescription for urgency can combine into something far worse than any one of them alone. Dr. Williams says this is the part almost nobody calculates, and because almost nobody calculates it, countless older adults are judged to be naturally declining when what is actually happening is chemical accumulation. Think of a person taking Benadryl for sleep, oxybutynin for bladder urgency, amitriptyline for nerve pain, and another nighttime product during cold season. No single medicine may look catastrophic on its own. Each may have been started for a legitimate reason. Each may even have seemed helpful at first. But together, they all press on the same memory-vulnerable system. Together, they create a burden the older brain may not be able to carry. The result does not always look like a side effect. It can look like personality change, confusion, fear, withdrawal, and the frightening beginning of dementia. This is where the story stops being about one bad pill and becomes a much more unsettling question. How many older adults are being labeled as naturally declining when the real driver is the total weight of what they take every day? And if that weight can be lifted, even partly, how much of the fog can come back into focus? That answer is where the story turns from fear toward hope, but only if someone finally reviews the full list instead of staring at one bottle at a time. That is why families cannot stop at the first reassurance that a person is calmer now. Calm is not the same as clarity. Quiet is not the same as comfort. Fewer outbursts do not automatically mean less suffering. Sometimes the medication has merely made distress harder to express. Sometimes the person has not become easier because they feel better. They have become easier because they are more sedated, more slowed, and less able to push back. That possibility changes every question a family should ask next, and that is why the final number is the one most people never hear about. It is not one prescription, it is the pileup, the overlap, the combined chemical pressure that turns several ordinary decisions into one dangerous outcome for families at home. Number one is anticholinergic polypharmacy, the cumulative burden created when several medications that interfere with memory-related signaling are taken together. Dr. Williams says this is the quiet engine behind some of the most preventable cognitive decline he has seen in older adults. People expect one villain, one dramatic bottle, one shocking prescription. The truth is often slower and more ordinary than that, which is why it gets missed. The real danger may be the stack, not the single drug that looks alarming in isolation, but the combined pressure of several medications nudging the brain in the same destructive direction every day. A person takes diphenhydramine to sleep, oxybutynin to control urgency, amitriptyline for pain, maybe paroxetine for anxiety, maybe a nighttime cold medicine during allergy season, maybe something else with hidden anticholinergic effects that nobody recognized because the label focused on symptoms, not on what the drug was doing inside the brain. One medicine blunts attention, another weakens memory formation, another slows reaction time, another adds sedation. None of them has to destroy cognition overnight to cause damage. They only have to keep leaning on the same fragile system long enough for the brain to stop compensating. That is why some older adults seem to decline in a way that feels frighteningly fast. Not because a single disease suddenly exploded, but because the brain was being hit from multiple directions at once. The family sees the surface only: missed names, confusion, sleepiness, poor focus, strange hesitation, a loss of spark. They assume the brain itself is failing. Sometimes it is, but sometimes the brain is signaling distress under a chemical load nobody ever added up. The difference matters, because one story ends in helplessness, while the other may still contain room for recovery. Dr. William once met a couple who brought in a shopping bag full of medications because they were terrified the husband had entered early dementia. He had become forgetful, withdrawn, and mentally slow in less than a year. He lost confidence driving. He stopped joining conversations at family dinners because by the time he found the right words, the topic had moved on. His wife said the hardest part was his expression. He looked tired from the inside. As each bottle came out of the bag, the story changed. A sleep aid with diphenhydramine, a bladder medication, a pain medication with strong anticholinergic properties, another product used only once in a while that mattered far more than they realized. Nobody had reviewed the total burden together. Everyone had treated each pill like an isolated decision. His brain, meanwhile, had been absorbing the sum. That is the trap of polypharmacy. Different doctors prescribe for different symptoms. Different pharmacies fill different bottles. Different family members know different pieces of the story. But the brain experiences all of it at once. When confusion arrives, the person at the center of it may be the only one too foggy to explain what changed first. So the decline gets named before the medication list ever gets understood. The hopeful part of this story is also the reason Dr. William insists families should never assume every sudden cognitive decline is permanent. Medication-induced fog can improve. Not always, not completely, not instantly, but often enough to matter. When the burden is identified early, unnecessary drugs can be reduced, safer alternatives can be chosen, doses can be adjusted, and the brain may recover more clarity than anyone expected. That possibility is powerful because it means review is not a formality. It can change a life, restore confidence, and give a family back months or years they thought were already gone. So what should happen this week if this story feels uncomfortably familiar? Start with a full medication review, not just prescriptions but over-the-counter products, sleep aids, allergy tablets, PM formulas, supplements, and anything taken only sometimes. Put every bottle on the table. Ask which drugs have anticholinergic effects. Ask whether any are duplicating the same burden. Ask whether the dose is still right for the age, kidney function, and current symptoms of the person taking them. Ask whether a medicine that made sense 3 years ago still makes sense now. Ask before the fog gets any thicker. Do not stop benzodiazepines suddenly. Do not throw away prescriptions in fear. Do not replace medical supervision with internet confidence. But do not assume that every decline is destiny either. That is the trap. People surrender too early because aging feels like an explanation broad enough to cover everything. It is not. Sometimes the story hiding underneath is more specific, more practical, and more reversible than anyone dared hope. Sometimes the thing stealing memory is not time itself, but the unexamined pile of solutions that slowly became a problem greater than the symptoms they were meant to treat. If you think memory loss always begins with age, you may already be looking in the wrong direction. Most families do. They see a missed appointment, a repeated question, or a wrong turn on a road someone has driven for years, and they reach for the explanation that feels easiest to survive. Aging, stress, fatigue, a rough week. But after 20 years in practice, Dr. Williams says some of the fastest mental declines he has seen did not begin with age at all. They began with trust in a bottle that looked harmless, ordinary, and safe enough to keep beside a toothbrush. That is what makes this story dangerous. The threat does not usually arrive like poison, it arrives like routine. A tablet for sleep, a pill for allergies, a capsule for heartburn, something to calm a restless bladder, something to settle nerves, something to make everyday life feel manageable again. Because the medication seems helpful, almost nobody asks the question that matters most. What if the thing easing one symptom is quietly blurring the mind? What if the real problem is not time alone, but chemistry repeated night after night until the brain starts failing in ways nobody connects to the medicine cabinet? Dr. William has watched that exact mistake tear through families. A father who once remembered every birthday begins mixing up names at dinner. A grandmother who balanced every bill by hand starts paying the same utility statement twice. A retired teacher loses the thread in the middle of stories she has told for years. The people around them reach for the easiest explanation. Stress, poor sleep, overwork, normal aging. Almost nobody points first to the medicine cabinet, and that delay is where the real damage often grows, because the medication causing the fog is still being taken every single day while everyone is blaming something else. So the countdown begins with the medication almost nobody fears. Number 9 is diphenhydramine, better known as Benadryl. Most people think of it as a simple allergy pill. Others know it as the little nighttime helper they use when sleep refuses to come. It hides inside cold remedies, itching formulas, PM products, and over-the-counter sleep aids. It is familiar, easy to buy, and so common that many older adults never imagine it belongs anywhere near a conversation about memory, confusion, or rapid cognitive decline. Yet inside the aging brain, familiarity means nothing. Diphenhydramine belongs to a group of drugs called anticholinergics. The name sounds technical, but the effect is simple and powerful. It blocks acetylcholine, one of the key chemical messengers the brain uses for attention, alertness, and memory formation. In a younger person, that blockade may feel like drowsiness. In an older person, it can feel like the edges of thought are being sanded away. Words become harder to find, focus becomes slippery, new memories fail to hold. The mind begins to feel slower without ever collapsing all at once. The most unsettling part is how ordinary the warning signs look at first. A person rereads the same paragraph twice. They walk into the kitchen and forget why. They lose their keys, then laugh it off. They wake up groggy and tell themselves they just slept badly. Day by day, the change feels too small to fear. Month by month, the fog deepens. By then, the connection to the nighttime pill may have vanished from memory too. That is how a medication earns years of unearned trust while the person taking it slowly becomes less sharp, less confident, and less like themselves. Dr. William remembers one woman whose family was quietly preparing for the worst. She had begun repeating herself at breakfast, missing church plans, and growing nervous behind the wheel. Everyone assumed dementia was beginning. Only when every prescription, supplement, and over-the-counter product was spread across the table did the pattern finally emerge. Her nightly sleep aid was built around diphenhydramine. She believed she was protecting her rest. In reality, she had been dulling her mind one evening at a time, with nobody around her realizing the bottle by her bed deserved more suspicion than sympathy. And Benadryl is rarely alone. It hides behind labels like PM, nighttime, severe cold relief, allergy plus sleep, and multi-symptom support. People think they are taking different remedies for different problems when they are actually swallowing the same brain-blunting ingredient again and again. That overlap matters. A little sedation becomes a lot. A little fog becomes a daily condition. A small mistake becomes a pattern a family cannot explain. Then someone adds another pill for the headaches caused by poor sleep, or another product for the anxiety that comes from feeling mentally off, and the chemical burden starts growing roots. That is why the first lesson is not panic. It is awareness. Read the labels. Question what you take every night. Never decide on your own to stop an important medicine overnight, but never stop asking what it might be doing either. Because if number 9 can hide in plain sight like that, number 8 is even more deceptive. It is swallowed by millions for a burning stomach, and almost nobody realizes what it may be draining from the brain long before memory starts to protest. What makes that so frightening is how long the mistake can survive without being challenged. The person taking the pill usually trusts it. The family usually ignores it. The symptoms usually arrive slowly enough to feel believable. And because the decline looks ordinary, no one realizes the clock is already ticking toward the next medication on this list, one that seems even safer because it is prescribed for the stomach, not the mind. And that is why the next bottle matters so much, because it does not promise sleep or calm. It promises heartburn relief while quietly changing the brain's supply lines. Number 8 is the proton pump inhibitor, the medication many people know by names like omeprazole and esomeprazole. These drugs are handed out for reflux, heartburn, and that relentless burn that climbs into the chest after meals or in the middle of the night. For many people, they feel like a miracle. The acid settles, sleep returns, meals stop feeling dangerous. The pain that once ruled the day quiets down. That relief is exactly why people stay on them far longer than they expected, often without anyone revisiting whether the original problem still needs the same level of chemical suppression. A week becomes a month becomes a year. Sometimes a person cannot remember when they started taking it, only that they feel trapped by it now. The moment they stop, the burning comes back harder, so they restart it and promise themselves it is only temporary. Then temporary stretches into years. Dr. Williams says that is when the hidden cost begins to matter. The stomach is not just a bag of acid. Its chemistry helps pull critical nutrients out of food, and one of the most important is vitamin B12, which the brain and nerves need to function cleanly. When acid stays suppressed for too long, B12 levels can drift down quietly. So can magnesium. So can the body's resilience. The change may not feel dramatic at first. It may feel like mental fatigue, weaker concentration, slower recall, tingling in the hands, lower motivation, or that vague sense that thinking takes more effort than it used to. In older adults, that picture can start looking disturbingly similar to the beginning of real cognitive decline. The cruel part is that proton pump inhibitors do not feel like brain drugs, so almost nobody thinks to question them when the fog starts building. That is what makes them so easy to overlook. They are not sedatives. They do not hit like nighttime medications. They work in the background through nutrient depletion, chronic dependence, and the false comfort of symptom control. Dr. William has seen people chase neurological evaluations while nobody checked whether the medicine that stopped the heartburn had quietly lowered the reserves their brains were depending on. Then someone orders another scan, another blood test, another consultation, while the one bottle taken every morning remains untouched because it looks too routine to deserve suspicion. And because many adults take other medications too, the story becomes harder to untangle. A person with reflux may also be taking a sleep aid, or a bladder medication, or an antidepressant, or a cholesterol drug. Each one adds its own layer of dryness, fatigue, sedation, or distraction. The reflux pill does not always create the entire problem on its own. Sometimes it simply weakens the system until the rest of the burden becomes harder to resist. The brain rarely collapses from one cause alone. It often loses ground because several small pressures are pushing in the same direction. If number 8 works in silence, number 7 works in embarrassment. That is one reason it escapes scrutiny for so long. Number 7 is oxybutynin and related bladder medications used for urgent, frequent trips to the bathroom. For older adults, overactive bladder is not a minor annoyance. It shapes where they go, how long they stay out, whether they travel, whether they sleep through the night, and whether they feel safe leaving home at all. A medication that reduces that constant urgency can feel life-changing, which is exactly why its hidden cost is so rarely challenged. But oxybutynin belongs to the same chemical family as Benadryl in one critical way. It blocks acetylcholine. The same brain messenger tied to attention, learning, and memory is the one this drug interferes with. That means a medication taken for bladder control can quietly strike at mental clarity. The terrible irony is that people who are already exhausted from broken sleep because of bathroom trips may blame their daytime fog on poor rest, not on the medication they started to fix the problem. The treatment becomes invisible, and the decline gets blamed on age again. Dr. William once met a man who had become afraid to drive outside his usual neighborhood. He described the feeling as if his mind could still see the road, but could not hold on to what it saw. Names slipped, dates slipped. The punchlines of conversations vanished seconds after people spoke. His family thought he was declining fast. What nobody had flagged was the bladder medication he had been taking every day for well over a year. The goal had been control. The cost had been attention, confidence, and the simple ability to trust his own brain again. The worst part is that many older adults are never warned clearly. They are told the medication may cause dry mouth or constipation. They may hear about dizziness. They rarely hear the full sentence. This medicine may also cloud your thinking, slow your memory, and hit harder the longer you stay on it. That silence changes everything. If a person does not know to watch for mental changes, they are far less likely to connect them to the prescription. And if number 7 can quietly do that, number 6 may be even more surprising, because millions take it to protect the heart. That is why embarrassment makes this medication especially dangerous. People do not always talk openly about bladder symptoms, nighttime urgency, or the fear of not reaching a bathroom in time. They want relief, not a debate. So when a prescription offers control, they accept it gratefully and move on. Months later, when names start slipping and concentration starts fading, the bladder medication rarely comes up first. The silence surrounding the symptom protects the silence surrounding the side effect, and both of them hide the real pattern. And because the symptom it treats is so private, many people never compare the timing of their bladder relief with the timing of their mental decline at all. Number 6 is the statin family, drugs like simvastatin and atorvastatin. This is where the conversation becomes more complicated, because Dr. William does not treat statins like villains. They lower cholesterol, reduce the risk of heart attack and stroke, and for many patients they remain an important part of long-term protection. That is exactly why the cognitive complaints tied to them are so unsettling. When something is prescribed to protect your future, you do not expect it to make the present feel mentally dull, hesitant, or strangely less familiar than it used to. Some older adults describe it in eerily similar ways. A blank where a familiar name should be. A sentence that disappears halfway through speaking. A sudden hesitation on a route they have driven for years. Others notice nothing at all. That is the problem with number 6. It is not a simple all-or-nothing story. It is a story of individual sensitivity, dose, age, metabolism, and the question of whether the brain in front of you is tolerating the medication the way the heart is. That uncertainty is exactly why the warning signs get ignored for too long. The brain is rich in fats and depends on delicate chemical balance. Some statins cross more easily into the brain than others, and that difference may matter in people who begin noticing fog, forgetfulness, or a strange flattening of mental speed after starting treatment or after moving to a stronger dose. Dr. William says the mistake is not assuming every statin causes memory loss. The mistake is refusing to consider the possibility when the timeline fits. Older adults deserve a conversation that is honest enough to hold two truths at once. A medicine can protect the heart and still create trouble elsewhere. He remembers one retired engineer who arrived carrying a notebook filled with examples because he no longer trusted himself to remember them. He had written down dates when he forgot the names of people he had worked with for decades. He had written down the morning he stood in his own driveway, keys in hand, and hesitated before remembering where he was planning to go. He feared something catastrophic. What complicated the picture was that his heart history made his statin important. The answer was not panic. The answer was careful adjustment, close follow-up, and a willingness to revisit assumptions. That is the theme older adults rarely hear clearly enough. A medicine can be useful and still deserve review. A person may need the class, but not the same dose. They may need cholesterol control, but not the particular version crossing into the brain most aggressively. They may need closer monitoring once cognitive symptoms appear. The danger lies in silence. If nobody mentions mental changes because they think they should simply feel grateful for heart protection, the discussion never happens. And then a reversible problem starts wearing the mask of an irreversible one. Then comes number 5, a category far more obviously tied to mental slowdown, but far less easy to escape. Benzodiazepines. Names like lorazepam, diazepam, and alprazolam. These drugs are prescribed for anxiety, panic, and insomnia, and at first they can feel like rescue. The pounding heart settles, the racing thoughts ease, sleep finally comes. The world that felt unbearable becomes manageable again. Dr. William understands why people cling to that relief. He has also seen the price it extracts when calm starts bleeding into dullness, dependence, and the slow blurring of everyday life. Benzodiazepines do not merely calm a person, they slow the nervous system down. For some older adults, that slowing becomes the difference between feeling normal and feeling wrapped in wet wool. Memory weakens, reaction time drops, balance worsens, emotional range narrows. Some people say they no longer feel panic, but they no longer feel fully present either. Days blur together, conversations are harder to retain. The mind becomes less flexible, less quick, less itself. Relief arrives, but so does distance, and many people do not recognize how much of themselves has faded until someone else says they seem changed. The cruelest part is that the longer a person uses these drugs, the more trapped they can feel. Try to stop suddenly, and anxiety may surge back harder. Sleep can collapse, agitation can spike. The medication that once felt like salvation begins to feel like the only thing standing between stability and chaos. That fear keeps people on it long after the side effects become obvious. Dr. William once cared for a woman who said the pills had given her life back during a season of panic. 3 years later, she quietly admitted that although she was calmer, she no longer felt completely present. That sentence stayed with him because it captured number 5 perfectly. The medication solved a real problem while quietly creating another. And unlike many sleep aids, benzodiazepines are not medications older adults should ever stop on impulse. Withdrawal can be dangerous. Any change has to be deliberate, gradual, and supervised. Yet the longer that conversation is delayed, the harder it usually becomes. And if number 5 can sedate the mind while convincing a person they need it to survive the night, number 4 may be even more deceptive. It is older, widely repurposed, and often prescribed for pain or sleep instead of mood.